Thank you. I'm here to channel the patient and consumer perspective at this conference. And I'm going to spend a little bit of time talking about some principles that patients and consumers pulled together for electronic health information exchange, a study that was recently published on how well California is meeting those principles, and some recommendations, or maybe I should call it a call for action at the end. After Congress passed the HITECH Act in 2009, Consumers Union convened several leading state and national organizations with a patient-consumer perspective. Some of them were civil rights organizations, some working directly in the health area. All were concerned about this more from the patient and consumer perspective, and may not have been as up to speed on many of the technical issues that we've been talking about here today. And it's for that reason that I want to spend a little bit of time sharing with you what they came up with on their own before we even got started. These were published in 2010. One of the reasons that Consumers Union did this is because in 2009, as all these efforts were being launched, everybody was saying, this is a patient-centric enterprise. It's all about the patient. And yet what we were finding is that patients were usually not in the room. We were usually addressing the technical issues for providers, for hospitals, for vendors, and so forth, but patients were not largely at the table. And so we tried to begin to fill the void. So we brought together 16 diverse organizations. You see a sheet up on the slide of the organizations that came together and endorsed the principles. And they actually worked for 6 months to come up with these principles. Now they're fairly simple. They are at the principle level, but again, I think it's useful to hear what they had to come up with. And they saw two functions for these principles. One was these were the principles that they thought patients and consumers would be using to evaluate the needs, whether their needs were being met in California as we were beginning to spend the $38 million that were going to come to California through the HITECH Act. And also to provide some help to policymakers, to doctors and vendors even, to guide their policies and to help them build their systems. So I'm going to take a few minutes to share those principles and to describe them for you before I get to the study which evaluated them. Not any real surprises here. First and foremost, they saw the benefits for individual care and then for population health. They wanted to ensure that all patients and consumers benefit fully and equally. They wanted the technology to be designed in a universal way to meet the range of needs. Definitely wanted to ensure privacy and security. Wanted to prevent the misuse of patients' data if that were to occur. They wanted to build partnership and literacy around HIT among patients and providers and public health officials. They wanted accountability, and they wanted enforcement. Now let me go into a little more detail about each. So we're all aware of the important benefits for patient and population health because we've been talking about them not only in this conference, but been talking about them for more than 3 years. What's important to know is that patients and consumers are also talking about these benefits. It isn't just doctors who are aware of the importance here. Patients understand this as well. They understand it because, for example, they have so much experience with financial services and being able to access their bank accounts through electronic access. They understand what that kind of progress towards the 21st century can mean in the area of healthcare. They realize that it will help make things legible, that it will help avoid errors, that it will help in sharing complete records with among their providers and specialists. They understand that it will help to improve the privacy and security of their health information. They understand that they haven't before had the possibility of encrypting their paper records, but there is the possibility of encrypting electronic records. So they actually see some privacy and security solutions here. They understand that this will be an important way to record and use a patient's linguistic and cultural competency requirements. So if the patient speaks a language other than English, the entire system will know how to meet this need instead of being ignorant about it. And they also understand the importance for population. I recall the lead convening that we had back in 2010 when there was a discussion between an advocate who thought that individuals always ought to be able to control their own health information and not disclose it to anybody, and somebody who was serving in a community of color was very surprised by this perspective and said, but the community needs to know the individual's information in order to be able to begin to address health disparities and chronic disease conditions. There was a recognition that we are, as individuals, we are part of a larger whole. This was the kind of conversation that was happening in the room. They also wanted to address as I said, inclusivity and equality. They wanted universal design, and here they emphasized they weren't thinking that this is one size fits all, that we're just building one system. Instead, they wanted to build, to use Mark's term, they wanted to build an adaptive system, one where the design allowed for different people with differing abilities. So linguistic and cultural competency requirements would be an example of a universal design issue. I should add the term universal design, I first heard about it back in the early 1990s in the disability context, where people were complaining about computers where the on-off switch had been designed and put at the back of the computer where they couldn't necessarily reach it. And they were saying if somebody really should have thought about all the communities that are using the computer and have put the switch on the front. Or for those who don't use things mechanically, perhaps even a voice-activated on-off switch. So this is the kind of principle that they wanted to see included as systems were being built. Privacy and security, we spent a lot of time talking about that, and in fact we relied a lot on the Markle principles, the framework that was discussed in part this morning. Concern not only about privacy and security, but about preventing the misuse of data, not to be misused in the provision of health care or restricting health care or restricting coverage. A recognition that there's a lot that patients don't yet know about electronic access to health care, so that there needed to be some literacy work. We should not assume that patients are going to walk into an office or approach this at home and know everything in advance. We actually, as leaders, we need to make sure that we're thinking about an education process to help in that regard. And lastly, accountability and enforcement. Very important that it's not just enough to lay these out as principles, but we want people to deliver on them. So where do the current efforts in California stand? Consumers Union commissioned Professor Robert Miller of the University of California, San Francisco, to study health information exchange in California and assess the degree to which the efforts so far here are or are not meeting the needs of patients and communities in California. It was recently published in Health Affairs in March of 2012. As far as I understand, it's the first of its kind in the nation, and we do think that it has important lessons for the rest of the country. Professor Miller selected 5 different healthcare organizations that collectively serve the range of California's diverse patient populations. So it's not up here on the slide, but there was a capitated integrated delivery system serving commercially and Medicare insured HMO enrollees. There was a physician management service providing EHR services for a large IPA, and that serving patients in HMOs, PPOs, and Medicare. There was a large public hospital with ambulatory care clinics, a large Medicaid HMO contracting with 2 independent practice associations, and a regional HIE exchanging among physicians, hospital, and labs. So this really is he's looking at a range of the efforts in California serving a range of the populations. Each of these organizations, he considered them to be a technology leader for the respective patient populations. And lastly, the survey occurred in August of 2010 to 2011. So just so you know what the time frame is, because we are moving rapidly. What he found is that alas, no organization's health information exchange initiatives was meeting the consumer-patient principles overall. So I put a brief summary on the slide, but I want to go over a little bit of detail about what he found for each of the particular principles that the consumer organizations came up with. The benefits for personal health. He did find that exchange within organizations was increasing, but that exchange with unaffiliated organizations was negligible. He found that only 2 of the 5 organizations had patient portals, and that even those 2 were not robust. So when you're talking about patient access, this is really an important thing. Only 2 of the 5 organizations were exchanging with public health agencies. They also noted that many times public health agencies were not able to receive the data even if they could transmit it, but that they weren't doing the transmission. None of the organizations could determine whether their patients were benefiting fully and equally from their efforts, and based upon his expertise with health information exchange, he believed that inequality existed. On universal design, he found that only 1 of the 5 organizations was considering universal design in its efforts. On privacy and security, good news. He found that all 5 were taking privacy and security seriously, but that none did much to educate their patients about their efforts and about the patient's ability to control data or to check audit trails and so forth. On preventing misuse, all of the organizations strictly limited the release of data. On partnership, HIT literacy, none of the organizations were educating their patients about how to use HIT to access and understand their information, other than providing a few brochures, which he found that patients weren't reading. On accountability, he found that there was virtually no accountability for realizing the benefits, no sort of structural efforts to ensure accountability. And on enforcement, he found that that was limited to privacy breaches, but not really to enforcing the overall patient protections that were listed in the principles. I want to be clear that I'm not saying any of this, and I don't think Professor Miller was saying any of this to criticize the efforts that many people are doing, the good efforts that many people are doing. It was merely to benchmark and to assess where we are so that we have some idea of what remains to be done, what's important to be done. So what then shall we do? And I want to get into some recommendations here. And I've been working in this area for 3 years now. And what I'd say is we really need something that structurally and systematically builds in patient access and use of their health information. And I don't think we've got that right now. Professor Miller identified some possible solutions in his study. He suggested launching public campaigns to increase literacy. That would be very important. You don't want, I would imagine that doctors would like patients walking in the door knowing why the doctor is using an electronic health record, and instead of taking time to ask, how does this work? So a broad public campaign certainly makes a contribution and actually helps everybody, providers included. Professor Miller suggested setting timetables for organizations to offer the web-based portals that are going to be critical for patient access. He suggested enacting rules that enable consumers to understand who has accessed their information and to correct the data. I mean, you've probably heard this around, that often it's the patient who is the best coordinator of their own health information. So you definitely want the patient to be able to correct the mistakes that are in that information. You want them to be able to have that access. And lastly, Professor Miller recommended funding and publicizing evaluations of health information exchange and their benefits and risks for patients, so that we are all learning the lessons that we need to learn. But I think we also need a truly systemic and structural approach. We have a Medi-Cal EHR adoption program in place in California because we saw the need for a systemic structural approach to get providers and hospitals to adopt electronic health records, to begin to engage in exchange, to make meaningful use of that, and we understood that they needed to receive payments. We do not have, however, anything equivalent to that for ensuring patient access and use, and I think we need to get an EHR patient access and use program going that approaches this systemically and structurally to build this in. We need this to be a parallel multi-track approach. I've heard the point, we need to get doctors up and running first. We need to get hospitals up and running first. And then when we're finished with that, we can start up with getting patients able to access and use their information, to which I think we actually need a parallel multi-track approach. It will often takes consumers and patients longer to understand some of these systems. You actually want them to begin to understand as doctors are beginning to understand, so that when doctors have the systems in place in their offices, patients are also up to speed and able to make full use of that. Now, what Dr. Kaiser said this morning about HIE and HI2T being a tool, not an outcome, I think if you build the patient access in structurally and systemically, you'll have exactly that. You will have doctors and patients partnering together around and using their health information, patients' health information together, and instead of having this being seen just as the HIE and the HIT tool being used for its own purposes. And I would say the time is now. 3 years in, we are fast approaching some of the goals. The HITECH Act said 2014 was when every person in the United States should have an electronic health record. And in 2009, when the Department of Healthcare Services convened a stakeholder vision for the EHR adoption program, one of the elements there was a vision element for patients. And it said by 2015, and I'm going to read it here because it's really important, by 2015, all patients of Medi-Cal providers with EHRs will have electronic access to their personal health record and self-management tools. Patient tools are affordable, actionable, culturally and linguistically appropriate, and accessible through widely available technologies. The PHR and self-management tools enable patients to communicate with their providers. These were patients' representatives, but these were hospitals, doctors, labs, an entire stakeholder community with this as a vision element. And we also lastly have the stage 2 meaningful use regs. They are proposed, but they too envision that patients will be able to download, access, and transmit their information. This is in the near future, and that is why I think the time is now for a systemic and structural approach for patient access and use. Thank you very much.
Thanks, Mark. I encourage some questions from the audience. We have our microphones up here if you'd like to come on up. I'll give you a minute to do that while I ask a very broad question, because we have 3 very different perspectives here. I think we have the provider, the consumer, and the HIO or the HIE perspective. And once again, please come up to the microphone so I don't have to ask the question. We're only going to have one. So since we have these 3 perspectives here, I'd like to know, and this is a tough one, we're not at the handle of the hockey stick yet, right, Mark? So everyone here is so committed to health information exchange, that's why we're here. But since we haven't gotten to the handle yet, what is your one piece of advice? And I know, Mark Savage, you just spoke to some of these recommendations, but what's the one call to action to get community-wide participation and that spike in HIE? And I'll throw it to Dr. Blair first.
Well, I've got to take you back to my last slide where I talked about leadership, infrastructure, and reimbursement reform. But I think first and foremost, step 1 is leadership. And it is the few that want to start this, finding the right people in the different within and between stakeholder groups that really can step out and get some kind of vision of where this will go and be able to articulate that within their stakeholder groups and their organizations. Because if you don't get some kind of uniform vision of this across the leaders in the community, it's very hard to get momentum.
Mm-hmm. Thank you. Mark Elson?
I agree. I think we have seen that efforts to expand by HIOs can be as challenging as startup efforts if they're moving from a region in which they have worked with an organic sort of set of stakeholders, and then move to a region where where they have full services to offer but don't have strong leadership. And so yeah, it's absolutely necessary.
Thanks. And Mark, your slide's still up there, so I hate to ask you the same question, but you gave a few recommendations. So what's the one most important?
Well, I want to come back to Professor Miller's recommendation of sort of public campaigns. I think we need to get this out in the general discourse. We need people talking about it, getting ideas. You're going to may have to be careful about that. You don't want to get things going where we're not ready for them. But if we have, I think you can see a lot more proposed solutions if we're all talking about it instead of just talking about it in a small circle.
Thanks, Mark. And I think we have a question from Eric Brown of California Telehealth Network.
Yes, we do. So great comments. I guess in a related question, in my travels out in rural California, Mark, I noticed some of those counties where we don't have active HIEs or HIOs, and in a lot of those cases, I hear healthcare providers who will say to me, I don't have enough critical mass to set one up. You know, I don't have enough people in my county. I don't have enough participants. And I just wanted to raise that and ask, for those counties that are noticeable, Siskiyou, Modoc, Imperial, where that seems to be the case, any observations you might have in terms of how do we get them on board and going forward?
Thanks, Eric. Good question. Yeah, it doesn't make sense for every sort of small rural area to go through its own, on its own, go through the process of establishing HIE services. So, you know, I think first we at the state level will be undertaking some activity to, for instance, accredit HISPs to offer direct throughout the state. So there will be sort of some steps along those lines. And then existing HIOs are looking at contiguous counties where they can expand, and not just contiguous counties, but also counties where they can sort of offer a franchised kind of instance of their services. But you know, it's a tough question, and I think maybe working with you and telemedicine efforts. There's an effort in the Santa Barbara and Ventura and San Luis Obispo counties called RAIN, which is doing great work in the telemedicine sphere and is interested in doing more with HIE. So I think looking for partnerships like that is necessary.
Other questions? And please introduce yourself.
Sorry, thank you. I'm Elza Schaefer with the Excita HIE in the Central Valley. Dr. Blair, I have a question for you. All of us are salivating and can't wait to, or hope to someday have similar results to yours. One of the issues we're facing right now is the sustainability model, really, and the evolution thereof in trying to attract both physicians in small groups as well as, and you mentioned FQHCs, some of the, we have a lot of very underserved areas and a lot of safety net and FQHCs, safety net clinic FQHCs. Are you able to say anything about your sustainability model and how in the early years you did attract physicians in, and whether your pricing has changed over time, and anything you could say on your pricing would be fabulous.
Sure. Yeah. I mean, there's different components of the sustainability model. I mean, if you look at the electronic health record piece, you know, that's been jump-started quite a bit with the stimulus. You know, we have a model for the smaller practices with a subscription fee that I think is reasonable and is competitive. So on the EHR side, that's moving and that's happening. But now that they're on EHRs and want to connect, we have some ideas of where we think it will be on direct. We do think it will be not dollars but pennies, and we think it's going to be really a commodity. And we suspect that it will be bundled with the EHR, ongoing EHR fees like the third-party software, but that's speculative. We're standing up our direct network now. Vendors will be integrating over the next year. That's going to play out in stage 2 meaningful use. But I think that that'll be a small number, and I do think that'll be part of the ongoing expense for the providers, and I think it'll be reasonable. On the health information exchange, as I mentioned, we really are fairly thin on the functionality. We have a lookup, a patient lookup, or a provider lookup of the patient longitudinal record. We handle the public health reporting for the hospitals, and we do some of the quality reporting. That whole system right now runs off of fees paid by the hospitals, and the state's getting involved in this now, and we've seen some of their pricing. It's very similar to what ours is now, but for about $50,000 to $75,000 a year for a 350 bed hospital, that covers all of their connectivity, and therefore gives the hospital all the physicians that work there access, and that underwrites access for the physicians across the Hudson Valley. So we're able to run the HIE, and it's sustainable just on those hospital fees. There's no fees for the providers for the HIE piece. Yeah.
Thanks, Dr. Blair. Another question from the audience? Okay, Lori's going to bring up our survey again, but thank you again to our panelists, Dr. Blair, Mark Elson, and Mark Savage.